Hello, everyone. I would like to welcome you all to the series of free webinar by the Hip Fracture Recovery Research, the Special Interesting Group of the Facility Fracture Network. I'm Jae-Young Lim, a professor of Department of Rehabilitation Medicine, Seoul National University, Korea. And I'm also co-lead of Hip Fracture Recovery Research Special Interesting Group, along with Dr. Katie Sheehan, King's College of London, UK. Today, I'm going to take the chair of this session with Professor Mohamed Awais, Queensland University. We are really excited to have three fantastic speakers about the implementing the delirium prevention in clinical practice, the success and challenges. Professor Awais, could you please introduce yourself?
Yes, of course. Thank you so much. My name is Mohamed Awais. I'm an assistant professor in the School of Rehab, Queen's University, Ontario, Canada. It's a pleasure today to be co-facilitating this webinar today, and I'm looking forward to the presentations. Thanks everyone for attending.
Thank you. Before we begin, I will quickly outline the plan of the seminar. The webinar includes three pre-recorded talks consecutively, and followed by a live Q&A session based on the presentation. Please type your question in the Q&A section or chat box to the right of your screen. I will deliver the question to the speakers that will be answered and discussed at the end of the presentation. Please enjoy the talks.
Thank you for joining us for this exciting webinar on implementing delirium prevention in clinical practice, success and challenges. My name is Katie Sheehan. I'm a physiotherapist and senior lecturer at King's College in London. And as co-lead of the Hip Fracture Recovery Research Special Interest Group, I'm briefly going to introduce you to the Fragility Fracture Network and to our group before introducing our first speaker. So the Fragility Fracture Network is a global organisation founded in order to create a multidisciplinary network of experts for improving treatment and secondary prevention of fragility fractures. The network believes that policy change can only happen at a national level, and multidisciplinary national coalitions are the most effective way to achieve this. Therefore, the network provides a global template for creating national alliances for policy change in as many countries as possible. Membership of the network is free and you can join via the website. So the network established 6 special interest groups, and our special interest group is explicitly focused on bringing together a multidisciplinary global network of those interested in advancing knowledge of hip fracture recovery. Our aims are to facilitate dissemination of new knowledge, identify opportunities for collaboration, and provide access to training opportunities. Again, membership is completely free and you can join over 1,000 existing members of our group when you sign up to the Fragility Fracture Network. Myself and Professor Jae-Young Lim are the current co-leads of this group, and we're really happy for you to connect with us if you've got any queries or suggestions via email or Twitter. Lastly, to note, we've got a fantastic virtual congress lined up this year, including international experts speaking to the latest evidence on the 4 pillars of the network, namely multidisciplinary acute care, rehabilitation, secondary prevention, and multidisciplinary national alliances. Would really highly recommend that you sign up and join us in September. Now, it's my absolute pleasure to introduce our first speaker today. Ms. Tarandeep Oberai is a PhD student and physiotherapist at Flinders University in Australia. So Taran is currently in the final year of her PhD, exploring contributing factors to delirium, interventions to reduce delirium occurrence, and the role of delirium in outcomes of older adults after hip fracture.
Good morning, everyone. My name is Taran. I am a physiotherapist by background. I am talking to you from Australia. I am an orthopedic physiotherapist as well as research coordinator for orthopedic surgery and trauma team. And I've been doing PhD part-time since last few years, and this session I'm gonna share with you what we learned along the way. We're gonna tell you how we started the project, how it ended, and everything in between. And I hope you enjoy and can learn from some of the lessons we learned along the way. So thank you for making time. So the title of my project basically was Delirium Prevention in Post-Hip Fracture Surgery, and I started the PhD from Flinders University. So just to give you a little bit of clinical perspective of our unit. So it's a level 1 trauma center based in South Australia in a city called Adelaide, and we look after approximately 400 hip fractures a year. And at the time when we did this retrospective case note analysis, 50% of our patients were experiencing delirium related symptoms. And the average length of stay at that time was 7 days, and the length of stay for the patients who experienced delirium was about 16 days. And if we just were able to reduce delirium and reduce the bed length of stay and the bed days, I think we could have saved about $2.4 million. Let's see what global evidence says. The global evidence says that in the next coming 10 years, there will be 100% increase in the hip fracture incidence. And as we all know, that delirium is one of the most common complication experienced once the patient goes through hip fracture surgery. And about 35 to 50% of the patient experience delirium related symptoms, and delirium is associated with worse prognosis, which includes worse functional recovery, decline in their cognitive health, decline in their physical health. They are more likely to be discharged to a nursing home, and they are more likely to die as well. So what is delirium? So delirium is acute confusion. It leads to disorientation. It's a global cognitive deficit, as well as it's multifactorial. Some of the risk factors associated with delirium are advancing age, existing cognitive impairment, pain, blood loss, post-operative. It's a very common post-operative complication. It's malnutrition, polypharmacy, and as well as anesthetic used. So within our project, the research question for us was, first of all, the population was that all our hip fracture patients, we wanted to incorporate some preventative strategies which were going to be implemented by clinicians. We did not have any comparator in mind, and we were interested in incidence, duration of delirium, hospital length of stay, as well as improvement in use of objective screening tool to recognize delirium. So every implementation science project, it has to be underpinned by a theoretical framework. So we chose to use the knowledge to action framework. Right at the core of the action framework is that we first look at the knowledge which exists, we synthesize the knowledge, and we choose which knowledge tools are going to be used. For our project, we chose to align our practices with the delirium clinical care standards. We synthesized the knowledge by conducting a systematic review of the literature, and so that for us, that was a center part of our project. And then we looked at the local problem, we adapted the knowledge to our local context, we came up with an intervention bundle, and we assessed the barriers and enablers to implementation of that intervention bundle, and then we looked at the efficacy of our program. So in this slide, I'll take you through the breakdown of each project we went through, and how we progressed and from one to another, and how one thing led to another. So basically, we identified the problem by looking at the retrospective case notes, and where we identified that there was a big problem within our setting. We also identified the gap in the knowledge of the nurses who were looking after this population of patients, and we synthesized the existing knowledge by systematic reviewing the literature and coming up with a plan of using multi-component interventions to target this problem. We were very lucky to get access to the hip fracture registry data of Australia and New Zealand, which is a national registry, and we utilized that data to look at that, is this a national problem as well, or is it just unique to our centers? We looked at the outcomes associated with delirium in this particular hip fracture population from Australia and New Zealand. We further analyzed the data to look at what are the predictors of delirium within this Australia and New Zealand population. We engaged with the clinicians from orthopedic unit, which included the doctors, nurses, allied health, as well as surgeons, to look at what are the enablers and barriers to implementation of the multi-component intervention bundle. We wanted to analyze that what was the actual practices which were happening within our unit and compare them to one of the international trauma centers in Netherlands. And we chose to do that because the clinical national guidelines to manage delirium in Australia as well as in Netherlands, they're both derived from NICE guidelines of UK. And so if the practices were based on those guidelines, then they should be quite similar, but we wanted to see that what are the actual practices in comparison to the national guidelines. So we used all this knowledge to come up with the intervention bundle, which I'll discuss with you that what included in the coming slides. So after we had developed the intervention bundle, we looked at what was the efficacy of the intervention bundle by analyzing the prospective data, as education was one of the key components of the intervention. We also looked at efficacy of the education intervention, and we used an existing knowledge survey to do that, and we had enough data to validate and psychometric property testing of that survey. So that's it. I'll share some results with you now. So the first step, as I said, was identifying the local problem. So our retrospective analysis of the case note suggested that 1% of our patients had pre-operative cognitive screening, 9% had post-operative cognitive screening, but almost 48% of our patients experienced behavior change symptoms post-operative. Then we took those results, and then we wanted to analyze the hip fracture registry data, and outcomes of interest within that project for us was hospital length of stay, in-hospital modality, long-term mortality, and discharge to residential aged care facility. So we analyzed almost 5,000 cases, and within those 5,000 cases, almost 37% of the patients experienced delirium during their hospital stay. Delirium led to 15% increase in the hospital length of stays, 76% increased risk of mortality, in hospital mortality, 30% increased risk of long-term mortality, and 24% increased risk of discharge to aged care institution or nursing home. Then the lead up of the next project was looking at the risk factors associated with delirium. So in this, we analyzed almost 6,700 patient data, and 39% of the patients experienced delirium-related symptoms. And some of the significant predictors were people who were aged 80 and over. Men were more likely to be impacted. There was people who had impaired pre-operative cognitive state, surgical delay, and people who were not able to mobilize on day one post-surgery were more likely to get delirium than the other population. In our knowledge synthesis, we looked at the systematic review of the literature, and our literature review suggested that if we used multi-component interventions which were non-pharmacological based, we were likely to have more good success with reducing incidence of delirium as well as duration of delirium. Some of the common themes which came was sensory enhancement, cognitive orientation, fluid and nutrition enhancement, communication, mobility enhancement, maintaining a good sleep hygiene, review of polypharmacy, and controlling pain. Our pre-intervention knowledge survey suggested that only 12% of our nurses had acceptable knowledge of management of patients with delirium. When we engaged with MDT team to look at their perceptions on barriers and enablers to delirium care, they suggested that delirium is common, but it's hard to recognize, especially the hypoactive delirium. There was a lot of hesitation on using the delirium screening tool because they all felt that there is enough paperwork. This is another piece of paper which is not really going to contribute much. But once they agreed to using the delirium screening tool, they felt that it is only worth their time if it led to a clear pathway of the care. And they all agreed that there is vital role of the family in caring for these patients. Our observational study, where we compared our ward to a ward, orthopedic ward in Netherlands, suggested that there was vast differences in practice. In the Netherlands, they regularly used orientation boards. They regularly used calendar clocks to improve the orientation of the patients. There were marked differences in their nursing practices as well. They consistently used delirium observation scale 3 times a day to assess delirium in these patients. There were regular enhancement of sensory input by glasses, hearing aid, dentures, and the patients were always dressed in their own clothes. And nursing staff or the caregivers or the hospital volunteers consistently engaged in hydration and nutrition assistance. And there was a lot more family engagement by providing them verbal and non-verbal information on delirium and caring for their loved ones. The patients were allowed to stay for extended period of time outside of the visitation time. The family were also allowed to stay overnight if needs be. The family were provided free car parking, as well as there was provision for family to eat in the hospital without any cost associated. So the interventions which we used within our project were education. We did some environmental restructuring. We recruited some change champions. We had infographics displayed all over the ward, and we had constant audit and feedbacks reports happening within the ward. Some of the example graphic used were the posters like. And another one of the key components which we used was education. It was a 3-step program. Step 1 was online modules. Step 2 was the informal in-service formal in-service as well as the informal discussions, and there were delirium care workshops available for participants to attend once they had gone through the step 1 and step 2. So now let's look at the efficacy of our educational intervention. So we felt in our post-intervention survey, we noticed that there was significant improvement in nurses' knowledge of caring for delirium patients. The knowledge was sustained over time. The nurses preferred the in-service, which was ward-based, more over the half-day delirium workshop, because that received the least participation. The efficacy of the intervention bundle suggested that actually it only had mixed impact. So first let's look at that just to remind ourselves that our primary outcome of interest here was incidence of delirium. The secondary were the use of delirium screening tool, duration of delirium, and the hospital length of stay. And the data collection method which we used was interrupted time series design. So our results suggested that the rate of change per month in patients with delirium decreased significantly by 19%. There was no significant change observed in duration as well as length of stay, but we did see significant increase in using the delirium screening tool. So there was 4.7% in the pre-intervention phase and 33.6% in post-intervention phase. So some of the lessons which we learned along the way was that although clinicians in our unit, they wanted to give the best care to hip fracture patients with delirium, they were doing so in a very non-structured way. There was no team approach. It was very ad hoc, and they definitely did not use structured screening and assessment methods. We also observed through our observation study that even though we have really good practice guidelines, but they will only be successful if there is a system level change within the whole hospital, and if there is a rigorous evaluation methods embedded into the system, it is likely that the practice guidelines will be more successful. Our nurses within our unit, they preferred the ward-based in-services over the online methods and the delirium care workshops. And we concluded that possibly they really liked that because it was present. They were present during the education in the ward. They did not have to come for the education session on their day off, and the time was made available to them to attend these education sessions. And one of the biggest highlights of this project, which we felt, was that we learned that if the goals of implementation of the local area, if they're aligned to the organization goals and organizational improvement targets, the likelihood of your own program is going to be successful. If we are working in isolation and the goals are not aligned with the organizational goals and there is no buy-in from the senior management, the likelihood is that we will receive a lot of hesitation, and the likelihood of success is quite low. So that's it from me. Thank you for your time, and we can take some questions from you later on.
Thank you, Taran, for a fantastic talk. It's my pleasure to introduce our next speaker. Anita Mian is a clinical nurse specialist at the Cleveland Clinic in the USA. Anita has over 15 years experience of implementing quality improvement initiatives for older adults, culminating in a 2016 Nursing Excellence Lifetime Achievement Award. She's a founding member and ambassador of the International Collaboration for Orthopaedic Nursing, overseeing publications of best practice guidelines for nursing after hip fracture.
Hi, my name is Anita Mian, and I am a clinical nurse specialist with certification in both gerontology and orthopedics. And I'm going to be sharing with you our experience with advancing best practice for delirium prevention at my hospital. The information I'll share pertains to a quality improvement effort by nursing to incorporate a delirium risk screen into our admission process. This screening process is but one initiative that emerged from an interdisciplinary team of clinicians who are implementing a number of strategies with the common goal of reducing incident delirium in our hospitalized older adult patients, both with hip fracture and with other admitting diagnoses. So to tell you a little bit about the place where this initiative occurred, my hospital is a 523-bed level 1 trauma center located in Northeast Ohio. We are a teaching hospital, and we are part of a prominent health system with an emphasis on research, education, and shared governance. We are also a certified stroke center and have achieved magnet designation from the American Nurses Association. For those of you who may not be familiar with magnet designation, it recognizes organizations throughout the world for demonstrating superior patient care. We have an orthopedic residency program and perform approximately 300 hip fracture surgeries a year. So in 2018, as part of a quality improvement initiative, we began to review our current practice as it pertains to care of hospitalized older adults. We focused specifically on delirium prevention strategies, and we looked at a high-risk population, that being the hip fracture population. Within our nursing protocol, we found that there is a statement that says nurses are to perform a delirium risk assessment on admission. However, when we looked further, what we found was that this process is not incorporated into admission documentation. And we all know that unless something is documented, it's difficult to measure or monitor. We then reviewed the literature looking for best practice recommendations, and what we found was that in 2011, the American Delirium Society had a strategic initiative which recommended that every patient be screened for delirium risk at every transition of care. Further, the recommendation was that the screening needed to be simple to use and consist of routinely available data in order to enhance its implementation and use. We know that most screening tools assess for cognitive impairment, but one of the challenges is how to assess cognition in an ill older adult, particularly those that are already suffering from dementia. We took a look at our current practice, and what we found was that nurses do routinely screen for symptoms that are suggestive of delirium using a brief version of the confusion assessment method, or the BCAM. And within our ICU departments, we use the CAM ICU. What we found is that the completion rate of this instrument is very high, 95%. However, we also found that the delirium prevalence rate as a result of using this tool is less than 1%. And that either suggests that we are not using the tool appropriately or that we are very, very good at preventing delirium. And what we settled on was the former rather than the latter. What we also noted, though, was that despite documentation of signs and symptoms of delirium in the neuroassessment that nurses perform, we would see things documented such as the patient is agitated, the patient is disoriented, the patient is confused, is lethargic. But then when we looked at the BCAM results, more often than not, they were scored as a negative. And that most often occurred in patients who had pre-existing dementia. Because as we all know, it's very difficult, isn't it, to tease apart what is baseline and what is a new behavior in a patient who already has some cognitive impairment. The concern and the problem with our failure to identify delirium using our assessment tool is that the prevention interventions that are associated with a positive BCAM finding are only released when that BCAM is positive. So if the BCAM is negative, there are no interventions that are revealed and therefore no interventions that are initiated. So we searched the literature looking for a delirium risk screening tool, one that could be easily incorporated into the admission assessment. And in keeping with the recommendations from the Delirium Society, one that had could be answered easily by nursing on admission. What we found was the Delirium Elder at-Risk tool. It was developed by Freder and colleagues. It had been validated in several populations, both pre- and post-operative hip fracture, as well as elective total joint patients. It consists of 5 questions with a yes-no format, and the questions relate to predisposing risk factors and can be easily answered by nursing on admission. The original screening tool also used the mini mental state exam to evaluate baseline cognitive status. And we had a conversation with the author of the tool to say that within our process, we do not use the mini mental state exam. It has now become proprietary, so there is a fee to use it. It consists of 30 questions and really does require a level of expertise to both administer and interpret the results. But we do have within our admission process an assessment for baseline cognitive status that involves questioning the patient and their family. And so because we already use that, we asked for permission to substitute our current process for the MMSE, and we were granted permission to do that. These are the 5 indicators that are included in the Delirium Elder at-Risk screen, or the DEAR. If the patient has a history of dementia, delirium, or is actively hallucinating, that is an automatic high-risk indicator, and the remainder of the screening really need not be completed in order to determine risk level. If the first question related to cognition is negative, then it would require 2 of the remaining 4 indicators in order for the patient to be deemed at high risk for developing delirium. And the remaining 4, as you see here, are aged 80 and older, vision or hearing deficiencies, requiring assistance to perform an activity of daily living, or daily use of alcohol or benzodiazepines. After we found the risk assessment tool, what we then decided to do was to apply it retrospectively to a 1-week sample of patients admitted to our hospital through the emergency department to see how many would screen at high risk using this tool. This was applied to all patients regardless of age and regardless of admitting diagnosis. What we found was that during the week of the 1st of September, there were 322 patients admitted through the emergency department, and retrospective application of the tool identified 8%, or 27, as being at high risk. Now, I will say there's a caveat here, because when we did our retrospective application, looking through the chart, sometimes it was difficult to find sensory impairment and functional deficiencies. So the majority of these patients who were identified because of age and cognition and alcohol or benzodiazepine use. We then looked within that 322 patients to see how many were age 65 and older, and there were 155. And as you can see, 15% of that age cohort tested high risk. And then we looked even further at those aged 80 and older and found that there were 62 within that population. And within that age cohort, 23% screened high risk for delirium. So we decided we would take another look at what happened to these patients during the time of their hospitalization. So in following the course of those 27 patients that were screened at high risk, what we found was that 4%, or 1, had a code violet team called. And if you're not familiar with that terminology, that is a team that comes when a patient is exhibiting behavior that is combative or harmful and helps to de-escalate that event. 7%, or 2, required the summoning or the ordering of a bedside care provider. Again, that usually occurs when behavior is of a concern that requires close monitoring. In the United States, we still use physical restraints, and 3 or 11% required physical restraining. 15%, or 4, were readmitted within 30 days of their discharge. 15% died, and 30% were newly medicated with a benzodiazepine. Now, because these events often occurred, one patient had, for example, both the code violet and a bedside care provider, the total number that this represents is 17 of the 27. And so what we decided after looking at this is, had the screening tool been in place, we had an opportunity to proactively implement prevention strategies and perhaps alter the course of hospitalization and make a significant difference in the hospital experience for these patients. Our next step was to share our findings and get approval to pilot the screen as part of our nursing admission process. While that seems to be straightforward enough, as others of you who may have engaged in an endeavor to change practice know, it's important to understand that changing practice can be challenging, and it is a social, political, and educational process that requires patience, persistence, and perseverance. So for our next step, it involved meeting with administration, with Nursing Practice Council, and various informatics groups in order to move forward with our plan to pilot this delirium risk screen. Informing staff of the planned practice change necessitated the creation of an online learning module, an informational flyer that was distributed electronically as well as posted on each nursing unit, and we also held in-person meetings with unit-based nursing councils, including those who work off-shift, as admissions happen at all hours. So this is an example of what the risk screen looks like embedded into the nursing admission process. You can see it falls right after the pre-hospital mental status questionnaires. And then the top example shows if the first question is answered yes, the screen is then determined to be a high risk. And the bottom example shows that if the first question regarding cognitive status is no, it requires then 2 other of the risk indicators to be endorsed in order for the patient to be considered at high risk. This drop-down menu of delirium prevention interventions, or the delirium intervention bundle, is revealed. And there you see a variety of interventions from which the nurse can select the ones that are appropriate. And this bundle is the same bundle that is revealed with a positive BCAM. But as I indicated earlier, oftentimes, particularly in patients with cognitive impairment, the BCAM will be scored as negative. But by having dementia or a history of dementia as a high-risk indicator, these interventions, which previously would not get initiated, are now available for implementation. They then flow to the nursing plan of care, and that allows the interventions to be seen by and acted upon by subsequent care providers during the course of the patient's stay in the hospital. So in addition to having nursing interventions made available for those at a high risk, on the provider side, we also created a high-risk banner to alert providers that the patient is at increased risk for developing delirium. You can see that on the top example, there is a teal banner that indicates high risk for delirium, because this will then allow the provider also to initiate prevention interventions as well. Perhaps reviewing of the medications that are being utilized or the dosages of medications that are being utilized. Also an opportunity to engage in a conversation with the patient and their family about the increased risk for the potential for delirium to occur. As we all know, delirium is a frightening event for both the patient and the family. Now, if that patient were to be found positive for behavior suggestive of delirium using the BCAM, that teal banner would be replaced with the pink banner that you see on the bottom in order to not have numerous banners being visible. So the teal would be replaced by the pink in cases where there was a positive finding for delirium. So we've had a chance to review some of our successes as well as opportunities for improvement. This slide depicts information from prior to initiating our quality improvement efforts and after doing so. Our quality improvement project began in the fall of 2018. And as you can see, from 2017, when we had a less than 1% prevalence rate, to 2020, we have seen a steady increase in prevalence rates using our BCAM assessment. You might think this is counterintuitive as being positive, but it suggests there's an increased awareness of the signs and symptoms of delirium, and our rates remain woefully lower than one would expect in a hospital of our size, so there is still work that can be done. We have a delirium order set that can be initiated by the provider for those that are positive for delirium. And as you can see, before we began our quality improvement endeavors, that order set was really not utilized at all. And now we are seeing that almost 30% of the time when we have a positive finding for delirium, that the order set is being used almost 30% of the time. And the inclusion of delirium on the list of issues that are or were addressed during hospitalization has also increased. currently last year we were at 34.2%. So a nice steady increase, but more work that can be done. So the good news and bad news with regards to our delirium admission screen, we have found that the screen is completed 88% of the time, and of those completed screens, 38% on average screen at high risk. The bad news is that 47% of those that screen at high risk did not have interventions documented. So we know that assessment without intervention is not prevention. So we took a closer look to see why is this happening. And here's what we found. The risk screen is not designated as a required documentation. All of the other factors that are on that admission flow sheet are designated as required documentation. So if nurses omit completion of the delirium risk screen, there's no alert or reminder to complete that screening. And that's extremely important since, as you recall, this is only done on admission. So we have initiated a request to Nursing Informatics to correct that omission, and that request is in the queue, and we are awaiting word that that has been changed. The intervention piece, which is extremely concerning, again, as we took a closer look at the process, what we find is that the risk screen is completed, and if that patient is indicated at high risk, the drop-down menu of interventions does not immediately appear with that risk screen. Rather, the nurse has to go to an interventions tab, which is separate, and then scroll down until he or she finds the delirium prevention bundle, and there the drop-down menu will be made available and selections can be indicated. Again, using our technology to improve our practice, we have initiated a request that the interventions be married up against the assessment in order to increase opportunity for completion, and that request is in the queue as well. I alluded to the interdisciplinary team that has been working on efforts to reduce incident delirium, and we continue to do that. We are currently in the process of formally validating the delirium elder at-risk screen, an adapted version for use in all hospitalized older adults, not just those that are undergoing orthopedic surgery. And our colleagues from the emergency department have developed a protocol for administering regional pain blocks on arrival for patients with hip fracture, thus reducing opioid load and corresponding CNS side effects. And also our anesthesia department has done a similar protocol whereby administering a regional pain block post-surgery to handle post-op discomfort and also allow the patient to be more fully participatory in physical therapy as well as meals. I would like to leave you with this saying by Goethe: knowledge is not enough, we must apply, and being willing is not enough, we must do. I thank you so much for your attention. I have included a few references, and we'll be happy to answer questions at the conclusion of these presentations. Thank you.
Many thanks, Anita. Again, it's my pleasure to introduce our final speaker today. Professor Allison Mudge is a professor at the University of Queensland and Clinical Director of Research and Education for Internal Medicine and Aged Care at the Royal Brisbane and Women's Hospital in Australia. Allison's research interests include implementing effective delirium prevention interventions for older adults in the acute setting.
So thank you for inviting me to speak for the Fracture Fragility Network. My name's Allison Mudge. I'm a physician based at the Royal Brisbane Hospital in Queensland, Australia, and I have the privilege of leading the Eat, Walk, Engage Delirium Prevention Program, which I will be talking to you about today. But first we might just recap on some of the main points from Taran and Anita's presentations. So firstly, I hope that you're now convinced that delirium is a common complication, particularly in our hip fracture population. It has really serious implications for patients. It can be very distressing, and it also results in longer stays and more other hospital-associated complications. But it's also got serious implications for staffing because the care needs are often higher for patients who are experiencing delirium for a range of reasons. Delirium is associated with very significant additional hospital costs, recently estimated to account for over $8 billion in additional health and social care costs in Australia each year. But unfortunately, we know it's still under-recognised often by our clinicians, and I think that this is for a range of complex reasons, partly linked to it still being really seen within the mental illness spectrum rather than necessarily as a physical illness. And this is because we still have actually quite a poor understanding of the biochemistry and the basic science of delirium. But we do have a really good sense of the clinical manifestations of delirium and how that comes about. And this is a model proposed initially by Sharon Anui a number of years ago. She really did a lot of the seminal work around describing the constellation of delirium and understanding the risk and precipitating factors for delirium. And she proposed this model where there are predisposing factors or vulnerability, which are things like age and underlying cognitive impairment and frailty, things that make you more likely to develop delirium with an insult, sensory impairment, a number of other factors. And that this has an interplay with precipitating factors or insults, which might be the severity of the initial illness, might be surgery, but it might also be elements of the care that we provide or fail to provide that add to these insults. And thus someone who has relatively low vulnerability, who's perhaps younger and is cognitively not impaired, might need a much more severe illness to experience delirium, whereas someone who is frail and has underlying dementia might need a very minor insult, a urinary tract infection or other minor insult to develop this unpleasant syndrome of delirium. So you can see how very clearly in hip fracture patients we often have a population who are largely vulnerable, so they're patients who often have frailty as manifest by their tendency to fall, patients who are usually in an older age group, who then are exposed to a very noxious insult with significant tissue damage, significant pain, but also are to some extent the victim of the care processes that we provide. So they're going to be a high risk group. What this model means is that there are a number of clinical implications. It's important that we recognise risk, and we can do that by really thinking about these predisposing factors on admission. And Anita's talked about an example of a risk screening tool. We could argue, in fact, that hip fracture patients are at such high risk of delirium we probably don't need any additional screening tools. But there are certainly a number of screening tools available, and they do help us to think about who's at risk and perhaps monitor them more closely. It reminds us that we need to try to remove the cause. So, for example, in the case of hip fracture, early treatment of pain, early management of the fracture are going to be pivotal to reducing the risk of this development of delirium. But it also tells us how important it is going to be to avoid harm. So both to try to reduce the amount of noxious insults that we're providing, and we're going to talk about how important fundamentals of care are to that. But also, even once a vulnerable person has developed delirium because of their insult, they're going to be at higher risk of further harm in hospital, and getting things right first time becomes even more important to try to mitigate those longer term impacts on length of stay and potentially on future dementia and future care needs. So what this means is that fundamental care needs, these delirium prevention interventions or delirium management interventions that Anita so nicely articulated in the previous session, and I've taken a shot from her slide here, really need to be delivered consistently to both to people who are at risk of delirium due to those vulnerable factors and also to those who've already developed delirium. Of course, these all sound like very simple things, and what they might look like on the ward might be individually delivered interventions, so making sure that people have a glass of water in reach, that they have their spectacles, that they have some activities to do, to read the paper or engage in craft activities, that patients are able to mobilise within their abilities. So here we have an amputee who's being helped with a stand transfer to be able to sit out for meals, and that reduces his risk of aspiration and increases his chance of consuming adequate calories. But we might also want to take that lid off his soup so that he's able to consume the more protein-rich part of the meal and open his bread roll to get adequate calories. So there might be some simple bedside interventions we could assist with there. There are also some ward-based interventions that might help support these fundamentals of care. So here you can see a lunchtime group on one of our Eat, Walk, Engage wards, assisted by volunteers and our allied health assistant, where older people have had a chance to walk to somewhere meaningful, to engage socially with other people, and to share a meal, which provides really good orientation about usual routines and practices. Or you can see this simple pet wall, which might be established in a hospital corridor to provide a meaningful place for people to walk to and have a discussion about their dog at home. So these can often be quite simple interventions. The really challenging word on this slide is delivered consistently. And this is not just about education or trying harder. This is about developing some systems that help our teams to do the right thing. And we know if we can do that, so interventions which have used consistent team-based delivery of delirium prevention interventions that are outlined on the previous slide, in now several meta-analyses, we've seen almost a 50% reduction in incident delirium occurring in hospital, and that's accompanied by a reduction in other hospital-associated complications such as falls. And this has significant implications, not just for the patients, for whom this is a very terrifying experience and associated with poor outcomes, and for the staff looking after them, for which it can also be a frightening experience looking after someone with delirium, and certainly more demanding in terms of care. But it's also good for our systems. And this is a cost effectiveness plan. This might not be a data layout that you're familiar with. So this is from hip fracture patients, important publication around the cost effectiveness of delirium prevention programs for people with hip fracture. And if you look at this slide, things to the right of the up and down line, so in that to the right hand side of the slide as you're looking at it, mean increased quality of life. Things to the left mean decreased quality of life. Things above the line means the intervention is more expensive in net costs, and the things below the line means the intervention is cheaper in terms of net costs to the healthcare system. And so you can see that bottom right-hand quadrant where you can see all the dots is the place for health interventions to be, cheaper and delivering better outcomes. And you can see that under a number of different simulations based on trial-based data, it's highly likely that delirium intervention programs are both cost-effective and improve patient outcomes. Now, of course, they require initial investment, but that pays back in terms of savings. So powerful cost effectiveness. But these are all simple things, so we would wonder why they wouldn't be happening anyway. I've already called them fundamentals of care. But the reality is they don't happen every day for every patient. We know from some data that I'm going to show you in a little while that less than a third of our patients of any age in hospitals, in hospital wards, medical and surgical wards right across our state of Queensland, less than a third of them are sitting out when their meal times arrived, ready to eat in the safest and most effective manner. A very small proportion of daytime is spent actually in an active and upright position, standing or walking and maintaining core musculature that's so important for maintaining functional status. And our patients, even though we find our hospitals terribly busy and frenetic and always with so many things for us to do with our brains and our hands, patients are actually lying alone in bed for nearly 2/3 of the time, staring at the ceiling. So these simple interventions are not happening in a consistent manner. And there are a lot of really complex reasons for this, and our patients are able to give us some great perspectives. This includes significant workload challenges. We've become highly biomedical, highly task focused, and delegating way too many tasks to our nursing staff, often at the expense of fundamentals of care. We often have cultural systems that don't particularly acknowledge or encourage our patients, and that don't provide optimal communication between team members and patients. And we have significant problems with the design of our environments. We've moved towards highly clinical environments that often are not friendly to the person with cognitive, visual, functional impairments, or that encourage family visitation. And sadly, of course, the pandemic has made this even more of a point of contention. So this is not about individuals trying harder, it's about trying to set up systems where we can gradually work through these common and individual ward barriers to try to make it more likely, on average, that our patients are going to receive these fundamental cares in a timely manner. And that's what our Eat, Walk, Engage program is set out to do. And it's explicitly based in an implementation framework for complex interventions in healthcare by multidisciplinary teams, which is called the IPARIS framework. But you will see from this that the kind of improvement cycles are pretty common to what was explained by Anita. So this idea of understanding what your current practice is, developing an idea of how you want to improve, and putting in small scales of improvement. But we do those improvements both at patient level in terms of individual strategies, at ward level in terms of how we might change our practices, change our environment, change our equipment, change our expectations and our messaging to patients, and also at higher level, at hospital and management level, in terms of educating staff about older person friendly design principles, as in this workshop, or educating people more about delirium and dementia so that there's greater recognition of cognitive impairment. So a whole range of strategies at multiple levels in the organisation, and they're going to need to fit really carefully with where the teams at those different levels are at in order for them to get traction. So this is really a program of continuous improvement. The main elements of our program, firstly, it's very much centred around the older patient, and whenever we start on a ward, we begin with detailed patient interviews that tell us what the experience is like on the ward at the moment, whether they think that these features of mobility, nutrition and cognitive engagement are important to them, which they always do, and what they see as barriers and enablers and how they suggest we could improve. And we take that data back to our team. This is done through the Eat, Walk, Engage facilitator, and they are there entirely as an enabling resource, so they support the multidisciplinary work group. They try not to do too much, although there are times that they will need to do things that are based in the organisational context. And they're supported through their understanding of the ward, through the older person interviews, through a lot of discussion with individuals and the multidisciplinary work group as a whole, and through the performance of some structured measures that we know are related to clinical outcomes, and I'll show you a couple of those in a minute. Once the team has a clear set of priorities and goals, know where the gaps are and know what their vision is for improvement, then we bring on a multi-professional assistant, just a few hours a day, who's able to assist in some of the tasks that the professionals know need to happen but don't always happen. And they're able to take delegation from medical nursing and allied health professional staff, and are a very valuable resource and really a mascot, I suppose, for the program, very visible. So let's talk a little bit more about those roles. Firstly, the facilitators. They can come from a nursing or allied health professional background, and we have people from a whole range of backgrounds. Here are some of our experienced and novice facilitators. Novice facilitators are trained by our very experienced senior team, both in gerontology and in implementation science. And they work very hard to bring a team together to work on problems of improving older person care through listening to the patient experience, doing some careful measurement, unpicking what the positive and negative features of the context might be, and understanding where they can improve. And as they become more experienced, they will also advocate more and more at higher levels in the organisation. They support a multidisciplinary work group, which are really the powerhouse of change, and it really needs to be improvement that's driven from the grassroots. And they do that through being better informed, being able to take a broader perspective about their current practice, and that often involves some difficult conversations about roles and strengths and weaknesses that need a lot of unpicking between team meetings, but are ultimately cultivating a real sense of pride about improvements in quality. And this is a lovely picture from our vascular surgical ward in our World Delirium Awareness Day last year. So really a sense of pride about what they're achieving in terms of delirium prevention. And then the multi-professional assistant is certainly a carrot in the model, well received by our multidisciplinary teams, although absolutely an improvement project in itself to work out how to embed a multidisciplinary position in a siloed governance system. But over time they become a very valued member of the team. They're able to assist with group activities. So for example, here's a nice morning tea for patients out on a courtyard. And they're also able to assist with some individual delegated clinical tasks, but they're not an expanded scope in terms of depth of clinical scope. They're really expanded in terms of being able to help specifically across a broad range of activities within an assistant scope of practice. As I said, we're founded in the IPARIS framework, and so we really take the ward around cycles of improvement, making sure that we really understand different stakeholder perspectives, we have valid forms of measurement, we put in improvements, and then we understand what works. And the bits that work, we sustain, and the bits that perhaps didn't work so well, or areas where there's still room for improvement, we then go back around that cycle. And there does tend to be a lot of back and forth between those phases. It's never quite as simple as it looks on a diagram. So our program began at the Royal Brisbane Hospital, a large tertiary hospital, and we have spread over the last 3 years through some very generous funding through the state government based on the effectiveness of our program, which produces almost a 50% reduction in delirium in a large trial that we conducted. We've been able to spread to 8 hospitals within the larger Brisbane metropolitan area and a large number of larger regional hospitals right up the coast of Queensland. This has created some interesting challenges. Queensland is a very, very large state, and there is significant distances between all of these sites, and so we've had to become very good at relying on video conferencing and other forms of virtual support. But our facilitators get a very high degree of regular support and networking with their co-facilitators that helps keep them focused and optimistic and supported through what can be really quite a challenging journey of improvement. And I'm not going to talk in depth about that, but I'm going to talk a little bit about some of the success factors. And I think the investment was very important. We were very fortunate to have trial advice just at the time that there was a ministerial interest in how we might improve care of frail older people. And so we were able to make a very strong case based on international cost effectiveness and our own effectiveness to say that this was a role worth investing in. And we've been able to recruit some fantastic individuals into those roles and also support them through a really very highly skilled senior team that it's just my pride every day to work with. But we have needed to get high level both from state government and individual hospitals and health service, and then right down to the ward level leadership through nurse unit managers. And that kind of level of engagement in multiple levels with multiple hospitals when we don't personally hold the funding strings has been a really interesting journey, and really understanding where people are at and what their particular goals and aspirations are, and trying to gently bring them along with on the ride has been really important. It's been supported by a fantastic program team, both in terms of skilled facilitators, but also in terms of skilled data management and good administrative support. And it's really powerful monitoring data that I think is really critical to our continuing success. And so I'm going to just show you a little bit of the data that we collect. And this will be familiar to many of you through hip fracture registries. So very similar, collecting process data across a large number of hospitals. But these are processes that you can see are really quite micro processes. So we do mealtime audits and look at the proportion of patients sitting out in a chair for a meal, and this is across a large number of medical and surgical wards in different hospitals. And you can see, I guess, if you look at that at the top frame, you can see that the striking things are that there's really substantial variation. So more than twofold variation between those places that are doing better and those places that are doing worse. Places will always say that that's because their patients are the most difficult and the heaviest, but we really are seeing pretty similar case mix. A large heavy medical ward is pretty much the same in any hospital in the world, I suspect. So I think that this is really explained by a lot of culture and practices and resourcing, a whole bunch of things, but it provides evidence that you can improve, and that's even stronger because we know that actually sitting out is very different across different meal times, even on the same ward. So really, if you can get 40% of people out for lunch, you should be able to get more than 10% out for breakfast. So we can unpick that kind of data. And the panel below shows after the first 12 months on our first tranche of rollout wards, you can see that we've managed to shift the whole curve to the right. So we've improved the average, only a small amount, but you can see that we've now got sort of the median, the belly of the curve shifting across to the right. Still some laggards and still work to do for many sites, but that's the kind of improvement that we're seeing that's really encouraging. And at individual site level, we're able to give feedback back to wards that have put in a number of specific interventions. Here you can see a really low-tech version of group dining on a general medical ward, just tray tables pushed together so people can have a chat while they're having lunch. And that ward was able to achieve some really significant improvements across those that they made that the focus of their improvement for that year, and they've really shown some improvement. Now their challenge will be to sustain that great performance and perhaps work on some of their other markers. So for example, the time spent mobile. And again, you can see really significant spread in the distribution of figures, and you can see some improvement over the first year. And even more important is the stories that we're able to take back from our patients and sometimes from our staff, both about why these domains are so important to our patients. And I love this quote about independence as the last line of defence, but also about how they've noticed the ward has changed, because a lot of patients, of course, do come back into hospital as you're changing and improving, and they're able to give some really lovely illustrations of cultural change on the ward. So we use a lot of qualitative data as well as measures. We're at a really interesting stage. We've rolled out to 18 hospitals, more than 40 wards, but we are going to have some challenges. So we've got some fantastic people in facilitation roles, but they're mostly young women, and so we have a fairly predictable issue with turnover of those facilitators, and they all need retraining as well as retaining. So that's going to be challenging, and also it can be hard. Often initial improvements can come relatively easily, but then there's a period where everyone gets a little bit bored with the idea, and maintaining that energy can be really challenging. Trying to maintain fidelity to the core features of the program under fiscal pressures, under organisational priority pressures is really challenging as well, and measurement is a really important component to that, so that and reporting through a central organisation. But also just keeping delirium, keeping care of older patients up on the organisational radar is a huge challenge when we're actually fundamentally ageist organisations, as most organisations are. And I think we have this real opportunity over the next 10 years, as the UN declared a decade of healthy ageing, to improve our culture around that. So in summary, over these presentations, I hope that you have picked up that delirium is common, deserves your attention. It's distressing and costly and preventable, which is important. We can improve awareness with a range of tools, both to identify risk and to diagnose it when it happens. But whether people are at risk or already have delirium, it's important that we can deliver the fundamentals of care. And doing so really requires a systematic and program approach. Wherever it's been effective around the world, that's been the approach. And that's going to need consideration of leadership, and ideally multidisciplinary leadership, strong teamwork at multiple levels, an ability to measure change, and above all, persistence through cycles of organisational change. Wherever you are in your journey of thinking about delirium, I hope that one of the presentations has given you some inspiration or some food for thought, and we look forward to discussing during the Q&A. And I'd really like to thank my fantastic team. It's lovely always to be the talking head around this program, but I come with the backing of an enormous and fantastically passionate team. And of course, some terrific funding, both from our hospital and Queensland Health. And thanks for Pascal for filming me today.
Thank you. It was a very nice and fantastic informative talks. So now we start Q&A sessions. Please, Mohammed, take a lead this session, please.
Of course. Well, I would like to thank one more time our panelists for really excellent presentations. I learned a lot from them. I'm sure all the audience share the same perspective with me. Okay, so before we go into the Q&A session, I would like to just highlight that I just shared in the chat a link for a survey about the webinar. It's a very short survey, so please take a minute or two to complete the survey. That would help us improve the webinars for the future. So please take a minute to complete the survey, and that would be highly appreciated. Okay, so we have a few questions, and I would like to start with a question for Tarandeep. So the question says, what's the actual role of physiotherapists in multidisciplinary approach in delirium management?
Okay, so I was just answering the question as part of the chat as well. So, you know, in our institute, we have really long way to go. And but as part of this program, we encouraged physiotherapists to mobilize the patients, hip fracture patients, as much as possible. And if due to pain or even cognitive impairment, they were unable to mobilize, there was strong emphasis on making them sitting out in chair on day one. But at the time of the project, the honest answer is that before the project, the role wasn't as precisely documented as we would have liked to. But now, actually, the Eat, Walk, Engage program of Professor Allison Mudge, we are one of the boards have taken up that program. So we are really hoping that once the success of that program is documented in one board, that we can uptake that in different surgical facilities as well. So we're hopeful.
Okay, perfect. Well, thank you very much. Okay, so I will come to you again, Tarandeep, but let me take a question for Anita. So Anita, you presented an excellent initiative you implemented and tested in your hospital. And the question is, what do you think for those who would like to follow your steps and implement such a larger scale initiative in their hospitals? What the most significant challenge they might face and they should prepare to mitigate and address?
So I think one of the major challenges is to really raise awareness, particularly to nursing staff, that there are many things that nurses can do that can make a huge difference in patients, particularly those who are vulnerable to developing delirium. I don't think that there's a full appreciation on the part of nurses who see these people every day as to the vital role that they play. So we have been working very, very hard within we have a shared governance structure, which means that nurses participate monthly in initiatives that impact their practice. So we've spent a great deal of time, not only with education in an e-learning sort of format, but we really go out and meet with staff on the unit, taking an opportunity when there is a patient who is suffering from delirium to really role model and work with them to sort of tease apart the various different aspects that contribute to this issue. So I think that's probably one of the major challenges is, from my perspective, is really sort of getting people excited about the fact that there's something that we can do that can make a huge difference for these patients.
Thank you for that. That's amazing. So let's move to another question, maybe for Alison, but also for anyone else in the panel who would like to participate. So such an amazing initiative. And the question says, delirium interventions usually are multi-component. So there are different components, and it's hard to tell which one of these components is the most effective. And so the question is basically, do we have evidence to help us identify which one of these components? Is it mobility? Is it nutrition? Is it medication review? Is it managing pain? Like, do we know? Do we have evidence to say this is number one, this is number two?
Yeah, that's a great question, and everybody always wants to do, multi-component light, don't they? They want to be able to do just the bit that helps and not the other stuff. And there have been, I've certainly seen a couple of reviews that have looked at this in terms of what are the most common components. So there are now a number of systematic reviews of multi-component delirium prevention interventions. And there's no easy answer. So most of them involve increased mobility, but there is really no evidence that any of these elements on their own will achieve the same results. And I think partly that is because of this issue where you're sort of tiptoeing around a little bit about, whose job is this bit and whose job is this bit, and this is what nurses should do and this is what physios should do. This is very much about us as a team seeing the patient at the centre of care. And the physio can be the person who, when they've taken them for a walk, sits them down ready for their lunch and opens their meal packet. The nurse can be the person who continues the exercises that have been prescribed by the physiotherapist. The doctor can be the person that says, did you do your exercises and did you eat your lunch? And really bringing a team together without and trying to press against these siloed boundaries, I think is a really important part of the program as well. So it's not just what you do, but it's the cultural change that you put in place to try to do the thing you're doing. And we've all three programs describe that it's about bringing people together. It's about having the conversations with leadership. It's about getting your clinical facilitators to be modelling the practice. It's about having the conversation about what is delirium and trying to segment all of those up to try to just do the bit you can do and put it in a task list, I think might defeat the purpose.
I would just add the other value of having a team approach is because of the fluctuating nature of delirium, so that there are times when you walk into the room and the patient seems to be just fine, and then occupational therapy will go in and come out and say to the nurse, oh, something is going on here. So that, I think, further emphasizes the value of having multiple eyes on this patient, and then a communication strategy that will share information to be sure that we are picking up those nuances that can suggest there's something going on.
And also very consistent information back to the patient and the family from all members of the team. So if everybody's on the same page about trying to get someone mobile, we'll each have our own role in that. And it might be for the doctors, it might be around better pain relief, or it might be about better integration of the pain relief with when mobilities change, but we all need to be able to explain to the family why that's important and empower the family to be able to help too. So both for the inputs and for the outputs, having the whole team on the same page is so important. And clearly nursing is so fundamental to this because they own the fundamentals of care, but the rest of the team need to be, they're supporting the message.
Excellent answers, everyone. So Anita, another question for you from Joanne Boehm. What will be the preventive effects of delirium management for high-risk patients?
So the goal is that what we're asking, what will we expect to happen by identifying these high-risk patients?
Yeah, I think that more the question is about the effect. So what's the effect on high delirium patients when we do delirium management?
So what we are hoping to have happen, particularly doing the risk screen that we've implemented. So this happens on admission, as I've said, and it's really looking at those factors that set that patient up to be more likely to develop delirium. By managing those, particularly those patients who have a cognitive deficit, we have an opportunity to initiate interventions that, using our current system, which waits until behaviors manifest, and then we begin implementing strategies to reduce the effect of delirium. By capturing these people up front and managing them in a way that will hopefully, if not prevent, which would be our goal, at least ameliorate the severity, that would really be the ultimate goal for our management strategy.
Thank you, Anita. So there's another question also, somewhat relevant. This is for everyone, but it's specifically about nurses. So feel free, Anita, if you'd like to take it as well. So the question says, what will be the vital role and active participation as nurses, especially in prevention and implementation and intervention, aside from filling up the risk assessment tool? So beside filling that risk assessment tool, how nurses can play a vital role in prevention, implementation, and intervening?
So the risk assessment tool gets completed, and then depending on what factors are contributing to placing this person at increased risk, there is a menu of interventions that are provided for consideration for implementation. So, you know, that's certainly a vital part, is not just doing the assessment, but we also then have to critically determine which interventions, and I don't know which ones are the most effective, wouldn't that be nice? But based on their risk factors, so for example, if it's vision and hearing, do they have their glasses and their hearing aids available? If it's cognitive impairment, you know, really inviting the family to be an active part of their care and engaging in that conversation with families. So nurses really do play a vital role in initiating those interventions, and then working with the provider as well. The provider is the one that sort of sorts through and tries to figure out what's causing this, the underlying cause. Does that make sense?
It makes a lot of sense to me. And if there's any clarifications, I welcome more clarifications from the rest of the panel. So another question here from Shirley de la Vega. What is the prognosis of post-operative delirium, and how does this impact discharge planning? So anyone in the panel, feel free to jump in and address the question.
So I'm happy to have a little bit of a go at that. So I think, and Tarandeep showed some nice data from the hip fracture group that, you know, certainly patients with delirium who experience post-operative delirium are going to have higher mortality, both in the short term and in the longer term, and longer lengths of stay, and often have significantly more functional impairment. And that plays out as more institutional discharge, but also in higher care needs from their informal and formal carers. So really significant implications. And the delirium itself is often still present at the time of discharge. So the patient often, we don't do very well at looking for delirium at discharge, and we don't do very well for supporting families who are caring for their relative who isn't isn't how they usually are, and that may last for weeks to months, the impairments in cognition. And there is now some compelling evidence that post-op delirium contributes to future dementia. So it is very important for future burden of disease that we prevent as many cases of delirium as we can. That's where the evidence is really strong. But it's also really important that we inform families, because we're sending people home with families, that thinking maybe a little bit slower, that there might be misperceptions, that and give them some strategies. And this so far is a little bit of an empty area in terms of models of care for post-operative care of people who've experienced delirium.
Thanks a lot. May I have a question? So I'm thinking about how can we adopt the program, the Eat, Walk, Engage is pretty pragmatic approach to manage the delirium effectively. And actually, in the routine clinical practice, we always have the challenge to maintain this program, especially when the specific funds are not available. I think we will be able to do with attracting the attention of our members and encouraging them in short-term period, but it is different to implement this program to the routine clinical situation in the long-term way. So, Professor Mudge, can you share any experience regarding the challenge when it was implemented at the beginning?
Yeah, so we began as a small clinician-led improvement. Myself and my colleague Prue, who's a physiotherapist who was working in the safety and quality unit, and it really drew on some other improvement work that we'd already done, but trying to use an implementation framework. And our initial intention was just to try to encourage local ward-based quality improvement, very much as Taran and Anita are explaining. And then I guess because we were able to develop stronger evidence as we expanded to more wards, and we set out in a very tailored way, we have a research background, and that allowed us perhaps to take a very strategic focus to being able to demonstrate benefits. But, you know, in the end of the day, we were in the right place at the right time. And so we've been fortunate in our case to get, you know, we have a publicly funded healthcare system here in Australia. That's a huge advantage for programmatic expansion. And the business case argument is different in the States. But certainly in the States, you know, the Hospital Elder Life program has been taken up by 200 plus hospitals, and there is the tools for that program include a business case. It's philosophically very, very similar to our program, but run in a slightly different way. So I think, again, you know, it's teaming up with people who have a good understanding of sustainability, planning for sustainability from the beginning, which is easy to say and really hard to do. Getting in the ear of as many decision makers as you can from the beginning, and thinking about what your pilot needs to show to get that next step. So who's interested? If it's the director of nursing, what do they need? If it's the director of medicine, what do they need to see? And it's you know, strategic planning around that, so that you can move from a small, all meaningful improvement is local. So you can start from a small improvement platform and grow from that. Yeah, but you know, all of these programs require resourcing at small level. That will be in kind, that will be your passion. But passion projects are not sustainable. So you need to team up with others. You need to get the support of others, and you need to look at what other people, you know, have these conversations with what other people are doing. Don't reinvent the wheel. You know, Taran's hospital, you know, hopefully you're going to be teaming up with us. We've done one pilot ward and we're really interested in supporting others. But again, that will require a resource arrangement between the hospitals. None of it comes for free, but it pays for itself. There's strong cost effectiveness evidence.
Thank you for your comments. So, Taran, can you tell us?
Yeah, I was just going to add that just to reaffirm what Alison was saying, that, you know, the challenges where I learned from, and that's what the focus of my today's talk was, because I don't want people to go through the same things which I went through, because as part of this PhD, this started as just a one-person project. And of course, along the way, I got a lot of support from the ward manager of orthopedic ward and the nurses and the champions. But because there was no senior management involved, you know, there was no, our goals of improvement, they were not aligned with the goals of improvement of the senior management, and hence the challenges and hence the hesitations and the mixed impact. Sure, we showed some impact, but I think if we had the buy-in from the core center of the team, from the CEO's office, I think our successes would have been a lot more. But I suppose I needed to go through that for my own journey. So and because I'm quite at the beginning of my own research career and own quality improvement career, I needed to see that for my own growth. And I'm glad that I went through that, and I met a lot of resistance and I learned a lot. So my 2 pence, as Alison said, buy in all the decision makers right at the early stage. Passion projects don't go on forever.
Okay, so please, Mohammed, can you take the Q&A? Thanks.
Sure, thank you, everyone. So we have also a question from Vanessa, and the question says, what specific pre-operative intervention were most helpful in reducing the outcome of delirium, pre-operation and post-operation?
Well, I can just tell you from our quality improvement initiative, and what I shared, as I said, was just from the nursing aspect. But I think managing the pain for these individuals when they arrive in the emergency department by using a regional pain block has been a tremendous benefit, not only for the patient, but for the nursing staff and the family. I mean, everybody has benefited. It took us a little while to get that moving, but that in combination with then a pre-operative administered regional pain block and reducing, we've done some data collection on this, and the amount of opioids that we have reduced by using these 2 strategies has been tremendous, and positive outcomes for patient, staff, and family as well. So I'd say better pain management.
I'm not sure if we have time for a last question from the audience. And the last question is from Erwin. And the question says, the question is about the current context of COVID-19 and the challenges present with restrictions. And the question says, it is more challenging now to manage and screen delirium during the time of the pandemic, especially with limited caregivers being allowed to take care of patients. And of course, shortage of manpower. So any tips in addressing this challenge?
Look, I think in Australia, I'm the wrong person to answer, because we've of course been so fortunate to now, although that may be about to change. But even for us, there's been so much disruption. So we've had relatively few cases, but we have clamped down to visitors despite a lot of advocacy about whether that's the right thing. And I think it is a huge challenge. There are some great resources available on the Hospital Elder Life Program website. So Hospital Elder Life Program hosted now through the American Geriatric Society, some really nice resources that you can use for patients in isolation, and we've developed our own suite that are very similar for our local facilitators to use. So even just having things like, you know, puzzles and exercise sheets and things that can still be delivered to patients in single rooms without a lot of manpower. But at some point we're going to have to really address this risk-benefit balance, because it is so dangerous for our vulnerable patients to be cared for shorthanded and with no familiar family there. And it's we need to really consider this. And I'd be really interested in Anita's perspective, because you'll have been far more immersed than us.
Yeah, it has been a tremendous challenge, and the use of technology to try to replicate having a family member is not necessarily, adequate, but it's the best we can do. And nurses have really, really been creative in trying to, make up for the fact that the family member can't be there. We also have delirium activity boxes on each unit with things in them, such as you have talked about, Allison, like puzzles or yarn or, bubbles or different things that, depending on the appropriateness, could be used with these patients. But we find that they're going all over the place. So the hip fracture patients aren't necessarily going to the hip fracture ward anymore. So they're finding themselves over on, GU. So that's a whole other challenge in and of itself. But we're getting back to normal. So that's good.
Okay, so it is very fruitful and very informed discussion. So it's time to close. I want to say thanks again to fantastic our speakers, and thanks to Mohammed always, and for all engaged in a fruitful discussion. So please respond the survey today webinar using the link at the chat box. Yeah. So thank you, everyone. I'm gonna wrap up this session. Hope you everyone enjoy this session today. Goodbye.
Thanks, Jae-young. Thanks, Mohammed.
Thanks, bye.
Thank you for having us.